Hi guys, welcome back. So today we're doing paper 9. So starting with cardiovascular examination, we need to examine the precordium. So we need to inspect, palpate, and auscultate. So precordium inspection and palpation for 2.5 points. Right, so starting with inspection, the things that we look for are any visible pulsations, especially in this area of the PMI where the apical impulse is, any scars from any previous surgeries, any lesions, any bruises, any ecchymosis, any deformities in the thoracic cavity, what else? Any like implantable pacemaker device, things like that. So for precordium palpation, we need to palpate for a couple of things. So we need to palpate for heaves and lifts. So heaves and lifts are sustained impulses generated by enlarged chambers, like enlarged ventricles, that rhythmically lift our fingers as we palpate for these. So to perform palpation of heaves and lifts, we just lay our fingers and our hand flat. So there are like three main areas that we need to inspect for this. So lay our hand flat on the second left and right intercostal spaces, and then on the apical area. So that's fifth intercostal space, mid-clavicular on the left hand side, okay? And then we need to palpate for thrills. So thrills are just palpable murmurs. So recall that murmurs are due to turbulent blood flow. So for thrills, we use the ball of our hand and we palpate in those exact same areas. So second intercostal space, left and right side, and the apical area as well. So fifth intercostal space, mid-clavicular left hand side. And if we feel the presence of any of these thrills in any of those areas, we need to auscultate them just to identify the actual type of murmur that we can feel, okay? And then for auscultation, we need to auscultate different points in the precordium for 2.5 points. So again, so for auscultation, we use our the diaphragm of our stethoscope. I'll show you guys. Oopsie. Okay, so we use diaphragm of our stethoscope to auscultate different auscultation points in the chest. So we can start from the base to the apex or apex to the base. It doesn't really matter. So I'm going to start from the base to the apex of the heart, okay? So this is my right side, this is my left side. It might be flipped in the video, just a side note. So starting with the aortic valve area. So it's the second intercostal space, right hand side. And then the pulmonic area, second intercostal space, left hand side, so left parasternal border, okay? So aortic valve area, second intercostal space, right parasternal border. Pulmonic valve area is the second intercostal space, left parasternal border. And then we have the Erb's point, literally one intercostal space below it. So third intercostal space, left parasternal border is the Erb's point. Then fourth or sometimes even fifth intercostal space, left parasternal border is the tricuspid valve area. And then fifth intercostal space, mid-clavicular, left side is where the mitral valve area is, or the apical area, okay? So just to recap, aortic area is the second intercostal space, right parasternal border. Pulmonic valve area, second intercostal space, left parasternal border. Erb's point, third intercostal space, left parasternal border. Fourth or fifth intercostal space, left parasternal border is tricuspid area, tricuspid valve area. Mitral valve area is the fifth intercostal space, mid-clavicular left hand side, all right? And then moving on to the respiratory system, so we need to examine the posterior chest. So palpation, tactile parameters, chest expansion, percussion, diaphragmatic excursion, and auscultation. So for palpation, we need to palpate for three main things. So firstly, so we're doing the posterior chest, so we're doing this from the back. We palpate for areas of pain and tenderness, okay? So there's generally 4 areas we need to palpate for, and we just so 3 on the actual back, and then 2 and then on the sides, okay? So we just palpate for any pain or tenderness in those areas, and then after that we need to palpate for the lung expansion. So we place our thumbs parallel to the 10th rib, so parallel to the lateral rib cage, and ask the patient to inspire and expire. So inhale and exhale. And as they inhale, the lung fills with air, so the lung expands, and therefore our thumb should move apart. And then when they exhale, the thumb should go closer together as the lung expels all the air, okay? So we look for the range of the movement and the symmetry of the movement. So if the lung expansion is not symmetrical, then this may point towards something like pleural effusion or like a pneumothorax. If the range of the movement is very minimal or it doesn't move so much, then this may point towards restrictive lung disease. After that, we need to palpate for tactile parameters. So tactile parameters are basically just palpable sound waves that are generated via the bronchopulmonary tree that gets transmitted to the chest wall as the patient speaks. So to feel for this, we just use the ulnar surface of our hand, and remember those 4 palpation points on the back. We just basically tell the patient, can you please say 99 as you feel my hand touch your back. So 99, 99, 99, and 99. So we feel for obviously tactile parameters, and if there's an increase in tactile parameters, this suggests consolidation because the frequency of the sound waves and the intensity of the sound waves are increased due to the change in the lung density. So in consolidation, the normal air-filled spaces of the lung gets filled with something else like a fluid or a mass that's growing inside the lung. Okay, so that would increase tactile parameters. And if there's decrease in tactile parameters, then this means that the sound waves are not traveling as efficiently, and this can be seen in cases where there's like a hyperinflation of the lung. So decrease in tactile parameters can be seen in patients with hyperinflated lung or like COPD, for instance. Okay. What else? So we need to also percuss the lung. So for percussion, we need to percuss the posterior chest in a step ladder fashion. So the way that we do this is we start at the top of the back, and there are 7 percussion points on the back. So we use our pleximeter finger and our plexor finger to percuss those 7 areas in a ladder fashion. So I wish I had a dummy to show you where to actually percuss, but let me just demo the movement. So we percuss. So that's the first, second, third, fourth, fifth, and then 6 on the sides, and then the 7th on the sides as well. So as we are doing it on the back, we go around the scapula. So we don't palpate over the scapula, we go around it, okay? And the normal percussion note should be resonant. So that's the normal percussion note in normal healthy lung. If there is dullness, then this indicates consolidation of the lungs. And what else? Okay, so we need to percuss for for percussion, I forgot to tell you. So I said if there's dullness, there's consolidation. It can also indicate that there's a mass underneath that's growing, so potentially a cancerous mass. If there is generalized resonance, then this points towards hyperinflation of the lung, obstructive lung diseases such as COPD and asthma, if there is unilateral hyperresonance, then this points towards pneumothorax. So another one for percussion is we need to percuss for diaphragmatic excursion. So diaphragmatic excursion is basically just a measure of how far the diaphragm moves during inspiration and expiration. So during inspiration, our lung fills with air and the diaphragm contracts. So it actually pulls itself down and the lung gets filled with air and the diaphragm goes lower, right? And on expiration, the diaphragm relaxes and then pushing that air up, helping the lungs expel all the air out. So it moves up, right? So to measure this, what we need to do is we need to ask the patient to take a deep breath in and then we percuss. So the diaphragm is located between the 8 and 10 intercostal spaces. So just keep that in mind when you're doing this. So ask the patient to inhale and hold it there. And then we percuss maybe from like the 7th intercostal space. So that's just at the tip of the scapula. We percuss downwards and then mark the lowest level of resonance. And then we ask the patient to breathe normally and then to expel the air, so expire fully and hold it there. And again, percuss downwards from the tip of the scapula to the lowest level of resonance. And what you should have, so there should be 2 marks, so one during inspiration and one during expiration. And the distance between those 2 points that you've marked should be between 3 and 5 centimeters. So that's the normal diaphragmatic excursion, okay? This test usually over calculates diaphragmatic excursion, but that's the normal. So it should move between 3 to 5 centimeters if you do this test. What else? Okay, so moving on to auscultation. So auscultating the posterior chest. So we use those 7 points we did in percussion for auscultation. So we just place our stethoscope on those 7 auscultation points at the back, right? We use the diaphragm of the stethoscope. And we place it on the patient's bare skin. We don't do it over clothing because clothing introduces some abnormal sounding sounds. So we place it on the patient's bare skin if possible. Also, as the patient inhales and exhales, we tell them to breathe through their mouth, not through their nose, because again, an obstructed nasal passage would introduce like abnormal sounding sounds. So when we're auscultating the posterior chest, we listen for things like the type of breathing. So is it vesicular? Is it bronchovesicular? Is it bronchial? So bronchovesicular is the normal breath sound. Mainly heard throughout the whole of the lung parenchyma anyway. So vesicular breath sounds are soft and low in pitch. And the inspiratory sound is longer than expiratory sound, and there's no gap in between. Abnormal sounding sounds include bronchial sounds and bronchovesicular. So bronchial sounds are abnormal when heard around the lung parenchyma, but not abnormal when heard over the main airways like the trachea and the mainstem bronchi. So bronchial breath sounds, the expiration is longer than the inspiratory sound, and there's a definite gap in between, and this is usually higher in pitch compared to vesicular. Bronchovesicular is again abnormal when heard everywhere else in the lung but the main airways. And in this type of breathing, inspiration equals expiration, and there's a definite gap in between. And we can also auscultate and count the respiration rate this way, making sure that the patient is not tachypnic. Also, we need to auscultate for any adventitious breath sounds. So adventitious breath sounds are just like added sounds that are superimposed to the normal sounds, normal breathing sounds. So examples include wheeze, crackles, pleural rub, and even stridor. So stridor is basically just a sign of an obstruction in the upper airway. Wheeze is a sign that the airways are narrowed, making it hard to expel the air out. Crackles are basically generated due to the collapse of the alveoli during expiration and then rapid air entry, forcing the alveoli open again, which creates that cracking sound. Okay, so I've explained all of this in paper 3 in much more detail, like what they actually sound like and things, and why we hear these kind of sounds. So that's for the respiratory system. Now moving on to the abdomen. Right. So the abdomen, we need to test for appendicitis. So we need to locate the Mcburney's point, perform rebound tenderness, Robertson sign, psoas sign, and obturator sign. So I think I did this in a different paper, but let's just go over it really briefly. Mcburney's point is the approximate location of the appendix. So Mcburney's point is, so the appendix is in the right lower quadrant. So the Mcburney's point is 1/3 of the distance between the anterior superior iliac spine and the umbilicus. If you draw like an imaginary line, my appendix would be around here, which is the Mcburney's point, 1/3 of the distance between the anterior superior iliac spine and the umbilicus. And for rebound tenderness, so rebound tenderness, also known as the Bloomberg sign, is basically we take our middle index finger, we press on the Mcburney's point, and we withdraw our fingers rapidly. So positive test means that there's pain upon the quick withdrawal of your fingers. So this is not very specific to appendicitis because, sorry guys, you could do this on other areas as well. And you can get the positive rebound tenderness, so pain upon the quick withdrawal of your fingers after pressing them down into the abdomen. So positive rebound tenderness just indicates peritoneal inflammation, but we use this to test for appendicitis. Robsing sign is when you press on the left lower quadrant and the patient feels pain on the right lower quadrant, so that's positive Robsing sign. psoas sign is have the patient lying supine and ask them to elevate their straight right leg up, and you place your hand on their knee and try apply resistance. So try push it down to apply resistance. And what this does is it activates the psoas muscle, which irritates the inflamed appendix. So the positive psoas sign is pain in the right lower quadrant as you perform the test. Obturator sign, similar. Have the patient lying supine, flex the hip and the knee, and then eternally rotate at the hip. And again, what this does, it activates those muscles around the appendix, irritating the inflamed appendix, causing pain. So that's, again, the positive sign for obturator sign is pain in the right lower quadrant. Nervous system. This is the last section, guys. So for nervous system, cranial nerve 5 and cranial nerve 7. Right. Cranial nerve 5 is the trigeminal nerve. So the trigeminal nerve has both motor and sensory function. So the motor bit of the trigeminal nerve innervates the muscles of mastication. So recall that that's the temporal, the pterygoid, and the masseters. So to test the motor function of cranial nerve 5, we ask the patient to clench their teeth together and palpate the temporal and the masseters, because these are the muscles responsible for jaw clenching. And then we ask the patient to move their jaw side to side and palpate the pterygoid muscles, because these muscles are responsible for the lateral movement of the jaw. So you feel for the strength of the contraction and the symmetry of the muscle contraction. And the sensory portion of the trigeminal nerve has 3 divisions. So we have the ophthalmic, the maxillary, and the mandibular divisions. So the sensory part of the trigeminal nerve basically is responsible for facial sensations, as well as the sensory part of the corneal reflex. So to test for the sensory function of the trigeminal nerve, we will need like a suitable sharp object to test for pain. So we can use like a broken end of a wooden cotton swab, as the sharp end, and we explain to the patient that this is the sharp end and the other end is the soft end. So we ask them to close their eyes and we stimulate. So for instance, this is the sharp end of the broken cotton swab, and this is the soft end. So what we do is ask them to close their eyes and we stimulate areas of the face using either the sharp end or the soft end to provide contrasting stimulus. So we test the temple region, the cheeks, and the chin. So basically we ask the patient to close their eyes and identify which stimulus we're touching them with, okay? If there is impaired pain sensation, we can test for temperature sensation. So it's exactly the same test. We just swap out the stimulus, basically using two different test tubes, one filled with hot water, one filled with cold water, and we test the exact same points in the face, okay? And for the sensory part of the corneal reflex, what we need to do is get like a cotton wool and using a fine wisp of cotton, well, first of all, ask the patient to take their glasses or lenses off, because contact lenses can diminish this reflex or can completely eliminate it sometimes. So using a fine wisp of cotton, we ask the patient first to look away from the stimulus at a distant object, and we just stimulate the cornea from the side, okay? We touch it with the fine wisp of cotton, and we look for the normal reactions such as the blinking of the eye and tear production of the eye, okay? So that's it for paper 9.